and the better off we will be in terms of containment and breaking the cycles of transmission. As I told you yesterday, and as advised by the experts, we expect that these numbers will continue to rise, since we have as yet not actually been able to hit our peak. This does not mean that we should lose hope. As a matter of fact, most of our hospitals that are attending to the positive cases have done an exceptional job in managing these cases. We are recording more and more recoveries from the disease, which is an indication that if the virus is detected early and proper care is availed, recovery is almost certain. This is why we have dedicated much effort to upgrade both infrastructure and human resource capacities in our healthcare systems. And yesterday, I think you heard that that effort will continue. There is supposed to be a meeting with the county response teams, committees, to further strengthen that capacity building of the health systems in the counties to be able to deal with this pandemic as we move on. Today, I'm delighted to inform you that we have discharged a record of 97 patients from various hospitals countrywide. This now raises our tally of recoveries to 849. This is the highest number of recoveries that we have recorded in a 24-hour period. As the infections rise, we are at the same time recording a high number of recoveries. This is commendable and is proof that contracting the virus is not a death sentence. I therefore want to thank our healthcare workers for this achievement. The rising number of positives also point to containment measures not being fully observed. The concern now is whether the increasing number of infections will challenge and even overwhelm our healthcare facilities. We should not allow ourselves to get to this point. We must ensure that we work together to reduce the chain of transmission and overcome this disease. Other countries have done it, and we can also do it by remaining focused on our overall goal. To achieve this, we should adhere to the containment measures, which include washing of hands, observance of personal hygiene, wearing of face masks at all times, maintaining social and physical distance, and avoiding public gatherings, among the other measures that the ministry has put in place. On the issue of wearing of masks, you may be aware that the WHO has issued new guidelines which require that people above 60 years, as well as those with underlying conditions, are advised to wear the N95 particulate masks at all times when in public places. This is because of the lowered immunity of individuals of that age or those with other underlying medical conditions. Additionally, caregivers to patients under home-based care program are also required to be wearing the N95 particulate masks when offering care to such individuals. This is aimed really at protecting the health care from contracting the disease from those that they are providing care to. In addition, the general public must continue to wear the 3-ply surgical masks and woven fabric masks at all times. Fellow Kenyans, today we have recorded 95 positive cases out of 1,096 samples that we tested in the past 24 hours. The total number of cases in the country to date is 2,862, and the overall samples tested so far is 98,439. Out of the positive cases, 92 are Kenyans, while 3 are foreign nationals. These 95 cases are distributed in the counties as follows: Mombasa, 56 cases; Nairobi, 13 cases; Busia, 10 cases; Kajiado, 6 cases; Kilifi, 3 cases; Kitui, Kwale, Garissa, and Marsabit each have 1 case. Note that Marsabit becomes the latest county to join that rank of counties that have reported a positive case, bringing the total number of the 47 counties in our country that now have recorded a positive case to 38. The cases are distributed in the following sub-counties. We begin with Mombasa with the highest, 56 cases. We find that 22 are from Vita, 13 from Changamwe, 7 from Nyali, 6 from Kisauni, 5 from Likoni, and 3 from Jomvu. In Nairobi, the 13 cases are from Kibra, 10, Langata, Kasarani, Dagoretti North, each have 1 case. In Busia, 9 of the 10 recorded cases are of truck drivers from Malaba border point, while Busia border point has 1 case. In Kajiado, the 6 cases are from Kajiado town. The 6 cases are from Kajiado town, 3, Kajiado East 2, and Kajiado North 1. In Nyeri, all 3 cases are of healthcare workers from Nyeri Central. In Kilifi, the 3 cases are from Kilifi North, while Kitui has 1 case from Kitui Central, Kwale 1 case from Sambweni, Garissa 1 case from Dadaab, and Marsabit 1 case from North Hall. In terms of gender, 57 of these 95 are males, and the remaining 38 are females. The youngest is a 1-year-old child, while the oldest is 72 years old. Again, sadly, we have lost 1 more patient from Nairobi to COVID-19 disease, bringing the total fatality number to 85. We send our deepest condolences to the bereaved family. In conclusion, I want to commend our healthcare workers of all cadres who are doing a great job under very difficult circumstances. You will note that today we have mentioned that there are 3 healthcare workers who have tested positive in Nyeri. Again, this tells you that our healthcare workers who are in the front line are also at risk, and from time to time we will see some of these health workers turning positive. But as we said earlier, turning positive is not a death sentence. People do recover even when they have turned positive. Our healthcare workers, being the frontline soldiers in this fight, are at a greater risk of contracting the disease. These are people who place their life on the line to protect this nation and provide care that is required by others. We should not take this for granted. We appreciate them, we thank them, and we salute them for what they're doing out there. As a people, let us recognize these sacrifices and collectively display our patriotism and compliance with the containment measures, for this is the only way to limit the spread of this virus. Thank you. Your name, please, and your media house.
And my first question is, what is the formula that is being used with regard to disbursing the funds to the counties? Because we've seen a number of governors complaining that the amount of money that they got is not equal to some of the challenges that they are facing. So if you could kindly explain that. Number two, it's also about the issue of home care based solutions, so to speak. And what we want to understand is, for those families that are going to be in this program, what is the metric that is going to be used to determine what patients go home and what are the other patients that are going to remain? And lastly, going forward, one of the things that we keep seeing is the fact that we're seeing a lot of donations coming into the country, yet we don't know how this money is being spent. We don't know how much we have so far, that is cumulatively, and we also don't know how much has been spent and how much is remaining. So if you could kindly explain to us how that is going.
One. Helen Aura from NTV. You said healthcare workers are at risk right now, and yes, we've seen the increased number of cases pertaining healthcare workers. Why is this the case, and what is the ministry or the government doing to ensure that our healthcare workers are protected? Number two, the president issued a directive to set up a 300-bed capacity in each and every county. Yet, we see that this will require more manpower. Where are we in terms of hiring more doctors, more nurses, or just more healthcare workers in general? Yeah.
My name is Purity Museo from KBC. You've said that it's important for the elderly and those with underlying conditions, as well as the caregivers, to use the N95 masks. But in the country, we've had limited number of these masks, and your ministry recommended that they should be reserved for the healthcare workers. Where are they going to get these masks from? And also the cost effectiveness, they are a bit expensive. Again, does this mean that the surgical masks and other masks are not effective enough?
Okay, Waziri, I'm Haemba from Ebro TV. Maybe my question is concerning about the home-based care program. Maybe how many patients is the country maybe planning to offload to go home to seek treatment at home? How many, maybe roughly? And then with the containment measures put in place by the government, the sealing off all the possible avenues, how did the case land in Marsabit?
Okay. So, thank you. Let me begin with the question from Jimmy Mbogo. A number of your questions relate to finances and financial management, and I have to say that I cannot answer those questions because that information is information that I think is best answered by the accounting officer at some point. Formula used to disperse to the counties. I'm aware that a sum of 5 billion Kenya shillings has been earmarked for the counties, and as far as I understand, that these resources have gone to the county under what we call a conditional grant, that it has gone to the counties. In terms of allocation of these resources, I actually do not know what criteria was used, but I would imagine that the same criteria that is generally used for allocation of resources to the county governments may have been applied, but I cannot be certain about that. I think maybe one of my officers here might have further information and could respond to that. I have referred to the question you asked about an accounting of the resources that have been put together and how they have been expended, and I think in due time you should be able to get, as media, a report on where we are on this. Home-based care solutions, what is the criteria of determining who is qualified to go for home care based? I think yesterday Dr. Patrick Amoth, the DG, actually went into detail on how this program is going to work, clearly stating that it's not everybody who is positive and does not require clinical management that will qualify for home care based. There have to be other requirements that have to be met. For example, it's all based on the fact that if you put somebody in home care based, you are confident that that person in his own home will be able to be contained in a manner that he or she does not spread that virus to other members of the household. So the need, for instance, to go and assess the home itself to determine whether the home has that capability to be able to keep a person in a self-contained part of the home that completely cuts off interaction with other members of the community. So basically a house that may have its own toilet and bathroom, the use of the linen being controlled, the collection and handling of the linen that is used, as well as other medical waste products. All of this is including the way that individual will be taken care of by the carer, what the carer will be wearing as they take care of this individual, how this individual will receive food, and how those utensils that are provided for that purpose are either disinfected or are made exclusively for the use of this individual. So all of these measures that will also limit transmission within that household are critical. They must be met. I think that is one of the most primary requirements. Once that has been met, then it is possible to consider that that individual and that household may qualify for home-based care. Okay? So I think I have addressed that. Helen Aura, healthcare workers at risk. Why is this so, and what is government doing about it? Well, you know, as I said in my presentation, healthcare workers are at the front line. And I have to say, it's not only healthcare workers. There are so many other workers in other sectors in government who are at the front line interacting with individuals. Take, for instance, the border points where we have truck drivers coming in. We have immigration officers there. We have police or security officers there. We have port health officers there. All of these will get in contact with first line, with people who may possibly be infected. We do know cases where these things could even be transmitted through documentation that is being circulated around those offices. So healthcare workers, yes, the healthcare workers are the direct ones who will be dealing with COVID cases, but we have a whole range of other frontline workers who are also exposed to this virus. This is a risk. It's an occupational risk. And therefore, from time to time, we are likely to see that these individuals may get infected, not because that they are not well protected, because I think in terms of, and this is answering the question what the government is doing, is to ensure that we are providing the necessary protective gear to these frontline workers, both healthcare workers as well as other health workers in this front line, we are providing them with the necessary gear to be able to make sure that they are protected as they go about their duty from contracting the virus. So we're talking about the PPEs, the gloves, the sanitizers, the containment measures that we have put in place, that they are in place and observed in these places in order to protect the healthcare workers. I have to say that in this regard, I think the government has done quite a bit in terms of ensuring that these PPEs and other commodities are available at those points where healthcare workers need them. And we will continue to place great emphasis on PPEs. In fact, if you look at the kind of expenditures that the ministry and the counties are undertaking, it is to a large extent, much of it is going into PPEs for the purpose of protecting healthcare workers, protecting others, and generally containing the spread of the virus. The directive by the President for the 300-bed capacity, remind me the question on that. What did you want to know about that directive?
Manpower.
Yes. Yes. Okay, yes, yes. I think this, definitely in this pandemic, the healthcare system has been stretched, both in terms of infrastructural capacity, but also in capacity of human resource, which is why, as the government made a commitment to be able to put forth resources to employ more healthcare workers. And you will recall that a few weeks back, His Excellency the President committed a certain sum of money, I believe it must have been over 1 billion Kenya shillings or so, solely for the purpose of employing more healthcare workers. So every effort is being made to boost up the number of healthcare workers. But it is not only getting healthcare workers in place, it is also ensuring that the healthcare workers who are in place are properly prepared to be able to deal with this pandemic. That requires investment in terms of training them properly so that they are able to perform those duties effectively. All of these things are being done by the national government, again in conjunction with the county governments. So these are areas that are being focused on in terms of building that capacity. Purity of KBC. Your comment was regarding what I talked about in terms of the masks wearing, and particularly I think you asked about the N95, whether it was absolutely necessary or not. I think the N95 is, of course, the most protective mask because of the nature and the way it is constructed. It is the most protective one that is used in those situations where that protection is necessary. Therefore, healthcare workers who are dealing with COVID-positive patients who are in the hospital, who are already, of course, shedding that virus, it's important for healthcare workers to use those masks. Equally, patients that may be in that condition where they are shedding a large number of virus would also be using those masks. Why should old people and those with underlying conditions use? If they can get this, that would be better than a surgical mask. But again, it depends upon where that individual is. Remember, we have said that most of our people who are over 60 years or those who have underlying conditions should try as best as possible to keep away and keep at home. That is the message we have been sending. It's best to keep at home so that you are not interacting with anybody and standing the risk of contracting the disease. So under normal circumstances where if people adhere to that, those people who feel that they have, they are at particular risk because of an underlying condition or because of age, it is best to stay at home. While at home, of course, among your family, if your family is fine, you don't really wear the mask all the time. But if you venture outside, you wear a mask. If you venture for shorter periods of time, this mask is good enough for most places. But if you are going to be in a place where there is close physical distance cannot be observed. For those particular group of people, the N95 would be the most appropriate mask to use. Okay, so that is just a directive by WHO. Of course, every country will have to look at that carefully and see what it can implement in terms of provision of these masks to the population. However, home-based care, how many stations are we setting up? Is that the question you asked? How many facilities? Huh? Okay, I think that will depend. It will be on a case-by-case basis, as I explained earlier, because we know how many positive cases we may have in a facility. We will further segregate those positive cases to those that are low risk in terms of transmission of the virus, to those that are higher risk. And generally, we have a high number of people who are now positive, who we keep in facilities, yet they are either asymptomatic or have mild or moderate disease. These are the kind of individuals who would qualify to be considered for home care, because we know from the course of this disease that people who have asymptomatic, when they are first detected and put in isolation, they remain asymptomatic. We keep following them until we find there is no virus. They are then released, and they really have not demonstrated any real clinical manifestation of the disease. There are those who may be mild or moderate, may have a cough and so on. They remain there, the cough subsides and so on. We find the virus is no longer there, they are released. It is those cases that we have picked up experience in terms of what we have seen so far in clinical management. Those are the ones that we will allow to be the first ones to be considered for home care based. Those that are slightly more sicker, what we call, they are in that group of more than moderate, severe, those definitely have to remain in health facilities, because the course of the disease also shows that progression from those stages to more severe stages is very fast. And therefore they need to be kept in a facility so that they can receive the kind of treatment and support systems that may be required if their path takes them along that route. So it will be a very judicious process where people will have to be looked at from that point of view, and then from the point of view of fulfilling the conditions within the home-based facility that they will be taken to, the homes they will be taken to. In this regard, we are also considering what we call community facilities, which could be, a large ward-like arrangement somewhere where some of the asymptomatic people can be kept and managed there. That is another possibility that we are also exploring. You talked about the Marsabit case. You needed further details on the Marsabit case? Okay, I think I will allow one of my officers to respond to that. I think they... Okay, I get your question. Your question is, we are picking something in Marsabit. Is it because we have not tested there before, so we have never discovered that there is something there? It's a valid question, and I agree with you. It is true. The fact that a county may not register, we may at this point be saying they have no COVID-19, does not necessarily mean that COVID-19 is not being transmitted in the community. Going in there and testing on a large scale, you might be able to find that there are a few of them that may be there. So that is why our testing keeps advancing in terms of where we are going and where we want to look at. In fact, from a safe point of view, the logic is, yes, you go to hot spots, but it is also important to go to places where nothing has been discovered, because you want to know before it gets too late whether a place that is negative might actually have community transmission. So we are very aware of those complexities, And in terms of our testing, we try to direct it in such a manner that we can also get to know what's happening. But I can tell you in the next couple of weeks or so, we shall see all 47 counties registering a positive. That is inevitable that it will happen. So allow me to two more questions.
Ana swali moja tu. Je, serikali inafanya nini kuhusu zile fedha ambazo zimepewa wahudumu wa afya walio katika mstari wa mbele kupambana na jinamizi la corona? Hadi sasa hawajapata fedha hizo. Mnafanya nini?
Okay.
Just one more question, kindly.
Let her ask.
Yes.
Let her ask. It's okay.
Just a quick one. Can you kindly elaborate on the testing mechanism? Because we've heard of a case where there are two individuals who went to get tested at Lancet and they tested positive, then went to get tested at Nairobi Hospital, and then the result came out negative. Kindly elaborate on that because there's a bit of confusion in
Okay.
Kenyans. Yeah.
Okay, thank you. Rachel, our citizen, yes, you can note from today's tests that there are fewer than what we have been doing, and that is a reflection again of our dwindling supplies. I think I had talked about it last week, but we have also been anticipating some new stocks to come in, and in fact, even as we stand here, I think there is some progress in that area. I will allow Dr. Kuria to comment on that, the supply chain with respect to the stocks. Whether a reinfection has been noted anywhere, this is a subject of great research interest to the WHO and the entire globe, because it's important to establish whether that actually happens. And what does it mean in terms of immunity? What does it mean in terms of immunity and the antibodies that one might be able to develop upon first infection? What does this mean? Does this happen? There is no definitive evidence as of now that can speak to this question, but it is an issue that is being looked at very carefully. In fact, there are studies that are looking at this to determine whether people do actually get reinfected in the course of once they recover and then may be exposed in the course of their work again, whether they do recover. Indications for now do not seem to show reinfection, but we shall wait and see as this evidence accumulates and is gathered to take up, because this is a very important information to know with respect to many things, including the use of some of these antibody tests as what you call immunity certificates with respect to a vaccine and the potential for a vaccine. This is a key question that needs to be asked, and there is focus on gathering in evidence on whether reinfection occurs. Emmanuel, mambo hiyo ya welfare, fedha ya welfare, it's true that there is a package that has been identified, as you know, and I think there's been a lot of progress in terms of how this package will be applied to the various cadres in the healthcare center, healthcare fraternity. Even today, this morning, I was having discussions with some of the unions in some of these cadres. I think there's progress being made there. There are certain issues in terms of who gets what and how much and so on, but there is progress in terms of discussion to be able to avail that resource as soon as possible to the frontline healthcare workers. Helen, on testing mechanisms, When you have very many laboratories that are testing, even though the test is a standard test that we have defined, it's a real-time PCR test. There also are basically different kits that are used to test this coronavirus, what is called SARS-CoV-2 virus. We try to use a standard test that targets particular regions so that those results are quite comparable or standardized between laboratories. So one of the things that we have done is to try to standardize the testing protocols of laboratories. Even with a standardized testing protocol, because it is humans who are involved in the process, there is can always be some level of error where tests may vary in terms of their results. And in that regard, we have a process within the laboratory pathology community of being able to counter-check results between labs. You can have what we call internal quality control procedures. These internal quality control procedures require that from time to time a laboratory may carry out tests on tests that are whose status is really known, just to see whether they get it right or not, and then fix where the problems are that might cause problems. Then there are external quality assurance tests where samples are distributed to a lab from an independent party, and the test results are then compared to see which labs actually have a very high standards of quality such that they do not return these false positives or false negatives. So we have a protocol that we have developed for quality assurance, and I think in time as we put that in place, we shall be able to help some of these labs that might from time to time return conflicting tests to come up to standard so that those tests then become very reliable. But these things happen in small percentages, but now and then you might get that kind of a problem. Thank you. Let me ask Dr. Kuria to come and maybe expound particularly on the testing area and any other area that you may want to say something. I know the truckers is an issue that we have been grappling with, and maybe you could say some things about that too.
Thank you, Kas Rashid. The question that Rachel asked was about the backlog in testing. Yes, indeed, there has been a backlog in various testing labs, more so in Mombasa and also in Nairobi here. But I can confirm to you that over the weekend, we've tried our best to clear this backlog, which mainly affected truck drivers. And most of these results have now been released to the respective recipients. This is not, of course, to say that we are still not facing issues with our supply chain management. We are trying very hard to sort out this, and I can indeed confirm whatever backlog was there will be cleared and will be history. As we speak, I can confirm that we're in the process of clearing a nice consignment of test kits, of manual test kits. And in the coming 2 days, I guess you'll be receiving another hundreds of thousands of automatic test kits, which therefore means we should be able to utilize all our testing capacities using the automatic, or at least quite a good number of automatic and manual operating systems or platforms. So at the moment, the backlog is minimal, and we are still fighting with it. We have empowered a lot of testing capacity in the western region, where most of the truck drivers are stuck. And as Kas Rashid has pointed out, you may be here reading from the media and TVs, and watching on TV, you are actually the owners of this. But the snarl up of traffic in Maraba and Busia. And as a ministry, and as actually not a Ministry of Health, there's a multi-agency force that is in Malaba and Busia trying to clear that backlog that started from diplomatic discussions with Uganda. And later on last week, we launched a team of health workers to go and try and get as many samples from the truck drivers who arrived at the border point without the requisite attestations to COVID-19 testing, or what you would call a certificate. So we have done lots of testing of these drivers. We go to the tune of 5,000 to 6,000 of them, and issued certificates, and we can confirm that the flow of traffic in Malaba has now eased out. We were on a two-lane traffic snarl-up, but as of today, we are actually on a single lane snarl-up. The jam has reduced from 74 kilometers to be just short of 34 kilometers, and it is still flowing. We are, of course, facing a few challenges because the systems in Uganda are down. That is the Uganda Revenue Authority. The customs office the systems are down, and there has been a slowdown in that clearance of trucks. But this is also being dealt with, and that will be an issue that we hope to settle before the end of the week. So for testing, I guess by Wednesday, we should be back. And moving forward, we put in place systems that we are doing our quantifications and justifications for our test, and we should be getting adequate test in time, and this should not be failed in any other time. Thank you.
Thank you. Thank you.